If you are an APOE4 carrier, what if I told you that two completely different research teams just discovered ways to potentially prevent Alzheimer's that don't involve removing amyloid? One team found a metabolic switch that completely restored memory in AD models, reversing the brain's energy crisis at its source, and the other team revealed that 75% of memory clinic patients have undiagnosed sleep apnea that silently damage the hippocampus every night, and treating it could protect against cognitive decline. These aren't theoretical possibilities. They are based on mechanisms we can target today with existing treatments. Hi, I'm Dr. Katrin. I'm a doctor of pharmacy and an APOE4 carrier. I'm also the founder of the Phoenix Community, a platform dedicated to helping APOE4 carriers beat the odds and outsmart Alzheimer's. Through my personal journey with APOE4, I dive deep into the latest research and translate complex findings into clear, actionable insights we can apply today to take control of our brain health. Today, we are exploring two groundbreaking presentations from the Alzheimer's Association International Conference that happened in July 2025, and these could fundamentally change how we approach prevention. So Dr. Katrin from Stanford discovered Kynurenine pathway that, when blocked, completely restored spatial memory in Alzheimer's models, working across both amyloid and tau pathologies. Then Professor Sharon NAISMITH'S from the University of Sydney revealed the hidden sleep crisis in dementia risk, showing that sleep interventions could cut our risk by up to 37%. This is huge. So what makes these findings so exciting for us as APOE4 carriers is that both involve treatments that already exist. IDO1 or IDO1 inhibitors that have passed safety trials and sleep interventions available at any sleep clinic. So let's dive into what these breakthrough discoveries mean for our brain health journey. So imagine your brain's neurons as a city that's lost power. The infrastructure is intact, buildings are standing, but without electricity, well, nothing works. This is essentially what Dr. Andreasson discovered happens in Alzheimer's disease, not because the power plants are destroyed, they're still here, but because a metabolic switch got flipped the wrong way, shutting down the brain's primary energy supply system. Her team at Stanford uncovered that astrocytes, basically the star-shaped cells that make up about 30% of brain cells and feed energy to neurons, well, these astrocytes undergo a devastating metabolic shutdown when exposed to Alzheimer's pathology. These cells normally act as the brain's energy brokers, converting glucose into lactate that neuron can quickly use for fuel, especially during high-demand activities like forming memories. So who is the culprit disrupting this vital process? Well, it's a pathway involving an enzyme called IDO1, that is short for endoleamine 2,3-dioxygenase, the key enzymes that converts the essential amino acid tryptophan into a compound called Kynurenine. Here's where it gets fascinating. The Kynurenine pathway has been studied for decades in cancer and autoimmune diseases, where it suppresses immune responses. But Dr. Andreasson's team made a discovery that contradicts everything we thought we knew about how Alzheimer's damages the brain. It's not primarily about inflammation, it's actually about metabolic starvation.
What we found was very interesting. So with vehicle-treated astrocytes, we get a really marked induction of kynurenine production, blocked with an IDO1 inhibitor, and of course you see the reciprocal pattern for its precursor tryptophan. Now what's interesting about kynurenine is it binds to a receptor called the aryl hydrocarbon receptor, or AHR, which then complexes in the nucleus with its partner, ARNT, and together this complex lands on DNA and transcribes AHR genes. However, if we block kynurenine production with an IDO1 inhibitor, there is no kynurenine, and now ARNT is free to complex with its other favorite partner, HIF1 alpha, which is a very important transcription factor that regulates glycolytic genes.
So what these researchers just described is like discovering that Alzheimer's doesn't destroy the brain's power. Again, it just flips the wrong molecular switch. So when kynurenine level rises, which happens when astrocytes encounter amyloid or tau, it hijacks a critical partner molecule called ARNT, preventing it from activating HIF1 alpha and the genes needed for glucose metabolism. This is catastrophic because the brain, despite being only 2% of your body weight, actually consumes 20% of our glucose. And neurons are almost entirely dependent on this glucose metabolism for survival. So the result, a complete metabolic catastrophe.
So here in the red are the astrocytes that were treated with A beta and tau, and they're hot red. They're trying to take up lots of glucose, but then in all the subsequent steps, all the way down to lactate, there is absolutely nothing. You're blocked at that step. And that's because there are no glycolytic enzymes. But in the presence of the IDO1 inhibitor, we saw this complete restoration of astrocyte glycolysis to normal levels. And I'm highlighting lactate here because of this very famous role of lactate in the astrocyte neuron shunt, where astrocytes take up glucose, they can metabolize it to lactate, which can then go to the neuron and feed mitochondrial oxphos.
Think about what this means. The astrocytes are desperately trying to take up glucose to feed the neurons, but they can't process it because all the glycolytic enzymes have been shut down. It's like having a full gas tank but a blocked fuel line. The astrocyte neuron lactate shuttle, discovered decades ago and now recognized as crucial for memory formation, completely breaks down. So neurons starve not because glucose isn't available, but because the metabolic machinery that converts it to usable fuel is shut down at the transcriptional level. But here's where the story takes an incredible turn. When Dr. Andreasson's team blocked IDO1 with a selective inhibitor called PF068, something remarkable happened.
Functionally, we tested spatial memory in the Barnes maze, and what we found was the very well described decline in this behavior in our amyloid models, but a complete restoration to normal when we gave them an IDO1 inhibitor. And this was also the case for tau mice. This was a mechanism that covered both types of pathology, A beta being extracellular and tau being intraneuronal.
Complete restoration. We're not looking at partial improvement, not slowing decline, but a complete restoration of spatial memory to normal levels. The Barnes maze test hippocampal dependent spatial learning, which is the same type of memory that helps us navigate familiar environment and is often first affected in Alzheimer's. And this worked whether the mice had amyloid plaques or tau tangles, suggesting the metabolic dysfunction is a fundamental feature of Alzheimer's regardless of which pathology dominates. That's critical for us since APOE4 carriers often develop mixed pathology. The implication become even more profound when we look at human cells. Dr. Andreasson's team made a startling discovery using neurons and astrocytes derived from Alzheimer's patients through induced pluripotent stem cells, iPSC technology, essentially taking skin cells from Alzheimer's disease patients and converting them back to stem cells, then growing them into brain cells.
But what our surprise was in the astrocytes. What we found is in the control astrocytes, not much IDO1 activity at all. The tryptophan levels didn't budge, neither did the kynurenine. However, in the AD astrocytes, there was a significant drop in tryptophan and a significant increase in kynurenine. These are iPSC-derived cells, but we actually have some ideas. But this was actually a big surprise. So just innately, AD astrocytes have an increased tone in the IDO1 kynurenine pathway.
So this is revolutionary. These astrocytes were created from stem cells, essentially reset to their most basic state with no epigenetic memory, yet they still maintain this metabolic dysfunction. It suggests that Alzheimer's involves a fundamental reprogramming of cellular metabolism that persists even when cells are given a fresh start. This possibly explains why late-stage interventions have failed and emphasize the importance of, guess what, early interventions. For us as APOE4 carriers, this is something we have repeated again and again in the Phoenix community. Really start your interventions as early as possible and pick the no regrets one. So when these researchers tested whether blocking IDO1 could rescue this dysfunction in human cells by using sophisticated mass spectrometry with carbon-13 labeled glucose to basically track metabolic flux, the results were very clear.
So you can see the control astrocytes have quite a bit of this. So they really make a nice amount of lactate on their own, but the AD astrocytes really didn't make much at all. So they really are deficient. However, in the AD astrocytes that got the IDO1 inhibitor, we had a really nice normalization of lactate production. So the IDO1 inhibitor works on these AD astrocytes to increase lactate production. Now we're going to put the astrocytes in with the neurons in a co-culture, and so the lactate diffuses, is exported out of the astrocyte, imported into the neuron, and now what you see is the same pattern. So we have AD neurons with not much lactate. It gets worse as you go down into pyruvate, into the TCA. You basically have absolutely no new lactate.
So the beauty of this discovery is that we don't need to develop new drugs from scratch. IDO1 inhibitor already exists and have been extensively tested.
So there is tremendous potential here. So the obvious thing is there are IDO1 inhibitors that have been developed in cancer, some of which are brain penetrant. These inhibitors actually have gone through safety as well as clinical trials for cancer. One of them went all the way through a phase 3. However, we could conceivably repurpose some of these inhibitors for Alzheimer's disease. We could potentially give them early at the MCI stage, for example, to really try to delay progression.
While this research didn't specifically examine APOE4 carriers, the metabolic dysfunction Dr. Andreasson discovered appears to be a fundamental feature of Alzheimer's that could affect all of us. Given that APOE4 is associated with reduced glucose metabolism in the brain decades before symptoms appear, and by the way, that's why we believe that the keto diet, while creating ketones that could replace glucose as a fuel, could be very beneficial for us. Well, this, in any case, you could use this metabolic rescue approach, which will save your glucose, which might be particularly relevant for our community. The fact that brain-penetrant IDO1 inhibitor have already passed safety trials means this could move to human testing relatively quickly. This potentially offers us a non-amyloid approach to prevention, which is always great because the side effects will not include ARIA, bleeding, for example. All right, a quick pause. If you're enjoying these breakthroughs, insights, and want to stay updated on the latest research that matters for APOE4 carriers, make sure to subscribe to this channel because we dive deep into the science every week, translating complex findings into actionable strategies for protecting our brain health. And remember to click on the bell to never miss one of my future videos. All right, now let's turn to Professor Sharon NAISMITH'S groundbreaking work on sleep disturbance in cognitive decline. While Dr. Andreasson revealed a metabolic switch we didn't know existed, Professor NAISMITH exposed a crisis hiding in plain sight, one that affects the vast majority of people at risk for dementia and is particularly concerning for us as APOE4 carriers who may have accelerated brain aging. So the evidence linking sleep to dementia risk is staggering. Professor NAISMITH presented data from multiple large-scale studies that should make every one of us rethink our sleep habits.
Sabia looked at the Whitehall study in the UK of nearly 8,000 people aged over 50, and after controlling for important risk factors like socio-demographic factors, mental health and medical factors, with the exception of OSA, found that there was 22 to 37% increase in dementia risk 25 years later. This is convincing evidence that sleep is an early and prognostic feature.
So a 37% increased risk from sleep disturbance alone, and this was after controlling for all of the other major risk factors. So for us as APOE4 carriers who already face up to 33x increased risk if you are homozygous and Asian descent, so it's around 15x if you are Caucasian. This poor sleep could be the factor that tips the scales. But here's what's even more alarming. Most people with sleep disorders don't even know they have them.
Most alarming is that OSA is extremely underdetected in the memory clinic. So our patients come in, only about 12% of people would report having an existing diagnosis of OSA, and even then it's not usually well treated. They do not complain about being sleepy, but when you do polysomnography on them, we have found that 75% of people would meet criteria for OSA, with 40% of those being in the moderate to severe ranges.
Cool, let that sink in. 3 out of 4 people in memory clinics have obstructive sleep apnea, where breathing repeatedly stops during sleep, sometimes hundreds of times per night, but only 1 in 8 knows it. They don't feel sleepy during the day because the brain adapts to chronic oxygen deprivation, so they assume their sleep is fine. Meanwhile, their brain is being damaged every single night through repeated hypoxic episodes that trigger inflammation, oxidative stress, and accelerated protein aggregation. So Professor NAISMITH'S team discovered exactly how this damage occurs, particularly during REM sleep when our most vivid dreams occurs and memory consolidation happens.
We found that REM oxygen desaturation did affect memory, but this was an indirect effect through the hippocampus. So REM oxygen desaturation affects the CA1 region of the hippocampus, which mediates the decline that we see in memory. This is important as we think about developing new tools to detect REM ODI and also to think about trying to slow memory decline in patients that we see in the clinical setting.
All right, the hippocampus, which is our brain's memory center and one of the first regions affected by Alzheimer's, is particularly vulnerable during this REM sleep. The CA1 region, Professor NAISMITH mentioned, is crucial for converting short-term memory to long-term storage. Every time breathing stops, oxygen levels drop and the CA1 region takes a hit. During REM sleep, our muscles are paralyzed except for the diaphragm, making us even more vulnerable to airway collapse. Over months and years, this repeated damage accumulates into measurable cognitive decline, particularly concerning for APOE4 carriers who may already have reduced hippocampal resilience. But it's not just about breathing problems. Professor NAISMITH's research revealed that the brain's natural sleep architecture, the intricate patterns of brainwaves during sleep, holds critical clues to cognitive decline.
In this study by Alenzio Paez and colleagues from here in Canada, they tracked people with mild to moderate Alzheimer's disease and showed that spindle density predicted mini-mental state scores and ADAS-Cog scores at 36 months. Also showed that there was a mediating effect of spindles on the relationship between CSF, p-tau scores and cognitive decline, suggesting that spindles may have a direct role in mediating the cognitive decline that we see in dementia. And not only of interest for disease progression, but importantly, interest and pivotal to memory consolidation.
Sleep spindles. So those are brief bursts of brain activity at 11 to 16 Hertz during the non-REM sleep are like the brain's filing system. Generated by the thalamus, they synchronize with hippocampal sharp wave ripples to help consolidate your memories from temporary storage to permanent cortical networks. When spindle density decreases, our ability to form and retain memories degrades. The fact that spindles mediate the relationship between tau pathology and cognitive decline suggests they are not just markers, but active players in disease progression. Professor NAISMITH's team found this is exactly what happens in mild cognitive impairment, or MCI.
And what we found in this particular study was that there were moderate to large effect size decrements in overnight memory consolidation in people with mild cognitive impairment. This was particularly evident in multi-domain MCI, suggesting diffuse network involvement may underpin this. And importantly, we found that poor consolidation was also linked to sleep spindle duration, again to integrity within the CA1 and CA3 hippocampal subfields.
So this means people with MCI aren't just having trouble forming memories during the day, they are failing to consolidate them at night. It's a double hit to memory function that accelerates cognitive decline. The connection to multi-domain MCI is particularly relevant for APOE4 carriers who often show broader cognitive impacts beyond just memory. Perhaps most concerning is what happens to the brain's waste clearance system, the glymphatic system, when we don't sleep properly. So this very recently discovered system, which works primarily during deep sleep, acts like the brain's janitorial service, using cerebrospinal fluid to flush out all our toxic proteins, including amyloid beta and tau. So this system relies on aquaporin 4 water channels on astrocytes, which, by the way, are the same cells Dr. Andreasson studied in the previous study we just covered, and is driven by arterial pulsations and changes in brain volume during sleep. Professor NAISMITH shared human evidence of what happened when this system fails.
What you can see on the graph on the right is when the contrast agent was given and how much of the clearance was measured at different points in time. In the sleep deprivation group, there is a lot of red areas in the cortical areas, and this shows that there is reduced clearance of that tracer in the cortical areas. And importantly, this reduced clearance was evident immediately at 24 hours, and the effects lasted up to 2 days after the sleep deprivation condition.
One night of poor sleep impairs brain clearance for 2 full days. The glymphatic system is 60% more active during sleep than waking, and this clearance is particularly robust during deep, slow-wave sleep. For those of us with chronic sleep issues, this means toxic proteins are constantly accumulating faster than they can be removed, potentially explaining why sleep problems often precede dementia by decades. Great! This is where both presentations converge on a very exciting reality. We don't need to wait years for new treatments. Solutions exist today that we can implement immediately. It's very easy. For sleep apnea, CPAP, which is continuous positive airway pressure, CPAP therapy shows remarkable protective effects.
CPAP therapy, of course, is the gold standard treatment for treating OSA. But certainly the follow-up studies that have looked at people using CPAP therapy show that users actually have a protective effects against MCI and AD incidents. This has also been seen in Medicare data. In smaller studies that we've conducted in the memory clinic, we do see that CPAP is associated with improvements in memory.
So CPAP works by delivering pressurized air through a mask, keep airways open during your sleep, preventing the repeated oxygen deprivation that damages the hippocampus. While compliance can be sometimes challenging, newer machines are quieter with better fitting masks, so it's more comfortable, and the cognitive benefits make it worth the adjustment period, especially for us as APOE4 carriers who can't afford additional risk factors. But perhaps the most exciting development in sleep intervention comes from a new class of medication called dual orexin receptor antagonist, DORAs. So these drugs target the orexin system, which is a network of about 70,000 neurons in the hypothalamus that maintains arousal and stabilizes sleep and wake cycles. Professor NAISMITH noted that Alzheimer's patients show a 70% loss of orexin neurons, suggesting the system is central to disease progression.
Where we have the most robust data in terms of pharmacological intervention is in the dual orexin antagonists, or the DORAs. There is mounting evidence showing that these are safe and effective for older people and people with Alzheimer's disease. Lemborexant and suvorexant in particular have been trialled in Alzheimer's disease. Essentially, these do improve sleep, and they do improve sleep maintenance in older people. I think what's really exciting about these is that the dual orexin antagonists not only improve sleep, but probably also have greater benefits for disease progression and pathogenesis.
What makes DORAs revolutionary isn't just that they improve your sleep quality and maintenance, they appear to directly impact Alzheimer's pathology at the molecular level.
So these last two studies, recent studies that have been conducted by David Holtzman's group and also Brendan Lucy and Randy Bateman, show that suvorexant and lemborexant probably have benefits in terms of tau phosphorylation. And this is really exciting because it gives us a new mechanisms by which we can tackle disease mechanisms, possibly through the sleep pathway.
So DORAs work differently than traditional sleep medication. Instead of sedating the brain, they block the wake-promoting signal from orexin, allowing natural sleep to occur. This preserves normal sleep architecture, including the crucial slow-wave sleep and REM periods needed for memory consolidation and glymphatic clearance. The finding that they also reduce tau phosphorylation, which is a key driver of neurodegeneration, suggests they are not just treating a symptom but addressing a root cause. Think about the convergence here. Dr. Andreasson showed us that blocking IDO1 restores brain metabolism, essentially re-energizing starved neurons. Then Professor NAISMITH revealed that improving sleep with DORAs not only enhances memory consolidation, but also reduces tau pathology. Both these approaches work through completely different mechanisms than traditional amyloid targeting drugs, and both use medication that have already been proven safe in humans. While neither presentation specifically examined APOE4 carriers, this fundamental mechanism, metabolic dysfunction and sleep disruption, likely affect all of us at risk of Alzheimer's. The difference for us as carriers may be that we need to act earlier and more aggressively to protect our brain health. Given our accelerated timeline and increased vulnerability, these interventions could be particularly impactful when implemented proactively. Okay, a quick pause here to talk about sleep optimization without going into pharmaceuticals, because these are the first things that you should do to optimize your sleep. So, 1. get sunlight into your eye first thing in the morning. When you wake up, just go outside, walk 15 minutes or do something outdoors so the sun can shine into your eyes. If you live in a place where sunrise happens very late because it's winter, you can buy some lamps that can have the same wavelengths to have the same effects. This is extremely important to help your body regulate your hormones throughout the entire day and basically tells your body this is the morning and then the night comes. At the same time, during evening, if you can, go look at the sun when it's sunset, because then the wavelength, the way the sun's light goes through the atmosphere of the earth is also making different subtle changes that your body is used to that. So when you see sunset light, it also helps your body decide, hey, it's time to sleep. So number 2, linked to that, you don't want to have any blue light during night. So if you have a device like a smartphone or a computer or laptop, just activates in the system the blue light filter that automatically activates after sunset and put it at the maximum. Yes, everything will look extremely orange, it won't be beautiful, but you'll have much better sleep. All right, point number 3 is to have a great environment for sleeping. So you don't want to have any light. That's including, those little red light that you have when your computer or your TV is on standby mode. So you want to avoid even that tiny amount of light because research has shown that that can disrupt your sleep. You also want to have a very cold environment. I actually like to put my aircon down to 16 degrees to be able to sleep properly, because naturally the temperature of your body decreases when you sleep and you don't want to feel hot because that would disrupt your sleep. Of course, you don't want to have any noise, and one of the best way to avoid all of these distractions when you sleep is basically to have an eye mask to cover your eyes so you filter out all the light, and to have what we call in France like boule quiet, I actually don't know the name in English, that you put in your ear to prevent hearing noises. A few other things. You want a ram down routine, so that's number 4. Basically don't have any excitement 1 to 2 hours before you sleep. So try to not be on the TV, on your phone for the blue light as well, and don't go into like some heated brainstorming or something. Just have the wind down routine, do some yoga, do some light exercise, stretching or meditation, or read a book, but basically don't put your brain into any exciting activities. Then number 5 is the last moment you have your meal is extremely important. You don't want to be digesting your food while you're going to sleep, so try to have your last meal ended 2 or 3 hours before you start to go to bed. Number 6 is about having a regular timing. You don't want to go to bed sometimes at 9 p.m. during the weekdays and then suddenly on Friday, Saturday, because you are going to sleep at 2 a.m. This will completely wreck your sleep. By the way, alcohol also wrecks your sleep, so just don't drink, or like keep it to 1 or 2 units of alcohol maximum. After that, I can guarantee you that your sleep will suffer. And lastly, try to track your sleep. So you have tons of different devices. For example, you have smartwatches. I wear one that can detect all your different phases in your sleep. You have a Neurons ring that I personally prefer because it's very, very comfortable compared to a smartwatch that is quite bulky. You have a Whoop bracelet that you can wear. You have actual EEGs that you can wear as an eye mask at the same time. So you have a lot of different devices. I personally prefer the Oura Ring, but pick the one that you like. What matters is you can only improve what you measure, and you want to measure your sleep to see that whatever interventions you're starting to apply make a difference, and that will keep you very motivated to continue to have these interventions and implement more and more. All right, let's conclude. Today's breakthroughs represents a paradigm shift in how we think about preventing Alzheimer's. Dr. ANDREASSON'S discovery of the metabolic switch shows us that neurons aren't dying, they're just starving because of Kynurenine pathway hijacks their energy supply, and we can restore it by blocking ID1. Then Professor NAISMITH'S sleep revolution reveals that up to 75% of people at risk have treatable sleep disorders they actually don't know about, silently damaging their hippocampus every night. And new medication like DORAs can both improve sleep architecture and reduce your tau pathology. For us as APOE4 carriers, these findings offer immediate action steps. Get a comprehensive sleep study if you haven't already. The odds are 3 in 4 of you that are just listening to this video have sleep apnea. So talk to your doctor about sleep optimization, whether through CPAP for sleep apnea, CBT for insomnia, or potentially DORAs like suvorexant or lemborexant. And stay tuned as IDO1 inhibitors move toward human trials. So their ability to restore metabolic function could be game-changing for early interventions. So what you want to do is to use today's science to protect our brain. Now, if you're ready to take control of your brain health journey, join us at the Phoenix Community, where we translate this type of breakthroughs research into practical strategies every day. Together, we're not just carriers, we're pioneers using science to rewrite our genetic destiny, or like I like to say, we like to beat the odds. Until next time, this is Kevin. Stay curious, stay proactive, and keep fighting for your brain health. Bye.